So, okay, we're in progress. Whoops. So for those who are new and don't know me, I'm Rhea Markowitz, and I'm from the Georgia Cancer Center hub for the teledermatology in rural Georgia program. Dr. Doug Patton and I will be serving as co-facilitators of today's session. So I hope everyone can put their screens onto gallery view so that when we aren't showing slides, we can see each other and have our conversations. I want to welcome our teledermatology in rural Georgia clinics and the healthcare providers there. So if you can, as I called out the clinic name, you can wave if we can see you. So we've got the East Georgia Healthcare Centers. We have Mount Vernon, Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, Swainsboro, and possibly what we hope is our newest clinic, Videa, and then the Phoebe Family Medicine Residency Program. So welcome to all of you. And then I want to welcome our TeleDerm team here at Augusta University. Our dermatologists are Dr. Loretta Davis, Dr. Harold Rabinovitz from the sunny South, and Dr. Kendall Buchanan. We may have some residents from our dermatology department and some medical students. And then, although we are not in our TeleDerm conference room, as we usually are, the TeleDerm team handling the controls are Brenda Santiano and Kenza Mamuni. Without them, we couldn't do this all together. And it's already been listed in the chat to please indicate, my dog is barking, your full name, your clinic name and location of the clinic where you are, and your role at the clinic in the chat. We have a lot going on today, besides my dog barking. But in the Augusta area, we're having thunderstorms that are passing through. And so hopefully we're all okay. I'm working at my home and it looks like it's all passed through where I live, but Brenda was cut off a little earlier. So hopefully we're all going to be still able to continue with the Zoom. But if one of us gets knocked off, we'll try and get back in as much as we can. I also want to point out that, well, maybe before I start talking about that, maybe I should be talking about what we're doing today. So can we have the next slide, Brenda? Okay, so we've done our introductions. The didactic session today will be given by Dr. Kendall Buchanan from our Department of Dermatology at AU, and she will be talking about the red scaly rash, and it looks like there are lots of them. And then we'll have a case presentation today from Kenji Yoshida, a third-year resident who is, third-year medical student, and who is joining us from, he's right now on rotation in the Atlanta area. In a few minutes, I'll be turning the session over to Dr. Patton, but before I do that, we're trying something new. We were hoping to try something new today. We wanted to do some Zoom polls during Dr. Buchanan's presentation, where she was presenting different cases, and we were going to do a poll, and you could choose which what the diagnosis was, and then we'd go through it all. Unfortunately, we haven't been able to make that work on our Zoom platform comes through the Project Echo platform, I guess you might say, and apparently the Zoom polls are not working on the iEcho. So we'll be trying to do a poll-like activity, which Dr. Buchanan and Brenda will do during the presentation. So now I will turn the session over to Dr. Doug Patton. He is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, and he spent most of his career as a rural physician. And so, and he's been a big, huge proponent of Project Echo, was instrumental in bringing Project Echo to the Medical College of Georgia. And so I will let Doug take over.
Thanks a lot, Rhea, and we'll move through this quickly because I want to give us plenty of time for the interaction with Dr. Buchanan and her presentation, especially since the Zoom poll didn't work out. So again, this basic reminders about Project Echo, what it stands for, and the concept behind it, that it moves knowledge instead of people. Next slide, please. And again, these sessions are designed to improve knowledge about teledermoscopy and teledermatology at the local level so that you can provide the best possible care as close to home as possible for all your patients and still have access to expertise to help you provide that care. Next slide. Again, these are not HIPAA compliant, so we ask that you please don't provide any PHI in your discussions. If you do need to if you have any questions, you can always email those to teledermatology@augusta.edu or type it into the chat if you need to. These sessions are recorded, as was mentioned earlier, and your participation is implied because you're still with us. Next slide, please. We collect data for all of the reasons noted. Next slide, please. And just the general Zoom reminders about staying mute. If you're not presenting or speaking, unmute yourself when you do. Chat's always available for you to type in questions or comments, or if you're experiencing difficulties. If you need to interject something, please use the reactions button, find the raise your hand, and we'll pay attention. If we're in the discussion, you can just speak up if you need to, but always introduce yourself, your name and where you're from as you do that. Remember to keep your cameras on as much as possible. Weather adds challenges to broadband capacity, so we understand if you need to take your camera off so you can stay connected to the session, but otherwise please keep them on. And let's see, I think that's the end of my slides. Maybe one more, or is that it? Next slide. There we go. So it's my pleasure at this point to reintroduce Dr. Kendall Buchanan as our featured speaker today. Most of you have experienced her expertise and benefited from that through a number of presentations, and the students who have presented and residents who have presented have also benefited from that expertise, and we're grateful for all she does to help us with these sessions. Today, she's going to try something a little different, and so we'll see how it works out in the best way possible to be a little bit interactive. And we're going to discuss something that we're all faced with, which is dealing with the red scaly rash. So with that, Dr. Buchanan, I'm going to let you share your screen, and remember to stop sharing when you're all done. Thank you, Dr. Buchanan.
Thank you, Dr. Patton. So we'll go ahead and get started. So the title of today's presentation is the red scaly rash in dermatology. We refer to this as papulosquamous and eczematous eruptions. These are my disclosures. So today the goal with this was to learn through cases, and really we're going to learn how to differentiate between common red rashes, recognize different presentations of dermatitis. And most of the cases that I'll go over today are indeed red and scaly, but you will see typical processes like chronic eczema. There's also a lot of post-inflammatory change that we need to be able to recognize as well. Give me just one moment, guys. Okay. All right. So essentially the idea of today was that we were going to have a Zoom poll. It didn't work out. That's okay. So if you guys feel comfortable for these first 7 cases, there's going to be a timer on the right. I want you guys to either, if you want to write it on a sheet of paper beside you, that's fine. Or my preference would be that you type it in the chat. And so you're going to have about 15 seconds. And for all the cases, you're going to choose between psoriasis, dermatitis, which can be acute, chronic, or like a contact dermatitis, pityriasis rosea, lupus, or tinea. Okay, you'll kind of get the hang of it. And then at the end, or in the middle, we're going to go over the cases. And then at the end, I'm going to have a select set of another few cases that will kind of test what you've learned. So we'll go ahead and get started. So this is the first case. And then we're going to do these first, and then I'll review them. So here we go. Question 1. So again, either type in the chat. So psoriasis, dermatitis, which can be acute, chronic, pityriasis rosea, lupus, or tinea. So here we go. All right, so that was question 1. Okay, second question. And if you don't know, that's okay. This is a judgment-free zone. All right, number 3. Number 4. There's 7 total. Number 5. I see the chats coming in, so that's great. All right, number 6. And our last case, the only one that's not red, question 7. Awesome. All right. Thank you guys for doing that. So let's review these cases, and then essentially I'm going to be going over some clues to the diagnosis. So case 1. So Brenda, do you know the most common diagnosis for this? Psoriasis. Perfect. And that's what it is. This is indeed psoriasis, common plaque psoriasis. And this is another example. This patient had this pretty much isolated to her lower legs. And so the clues for diagnosis of psoriasis include these well-demarcated borders. That's a clue that is fairly reliable in typical plaque psoriasis. You can also see this fine micaceous scale. And essentially what mica is a mineral that makes these very thin plates. It's like a silicate mineral. So you can think about it like this. It's just very, very thin layers that easily peel off. And then one pearl with psoriasis, in contrast to eczema or dermatitis, is that psoriatic plaques often lack secondary infection. So you're not going to see the typical yellow crust, weeping, or secondary infection. And that's because in psoriasis, there's upregulation of antimicrobial peptides. So these patients rarely have a secondary skin infection. And then this patient was, because she had it on her lower legs and she was fairly resistant to topical steroids, she was a horseback rider, and so she had a lot of trauma from that. So we started her on a biologic, an IL-23 inhibitor, and she was pretty clear after 4 months. You will still be able to appreciate these post-inflammatory changes. You can see some mild erythema, but notice all the scale is completely gone. All right, what about for our second case?
Psoriasis and lupus.
Okay. Yes, so this, great job, guys. This is another example of psoriasis in a patient with darker skin. And so this is actually how he presented to me. Mostly the chief complaint was alopecia or hair loss. And so you can see here that this was very acute. There's still a lot of erythema here, that background redness. And then you can also see the orange arrow points to that thin, like the micaceous scale. And so for this case, the clues to diagnosis are, again, those well-demarcated borders. You also see the scaling. You can see it on his lower leg and the plaque above. And then alopecia is fairly uncommon with psoriasis, but if you do see it, it typically presents more like a telogen effluvium process. So that's when you get sort of an onset of hair loss that's diffuse. So there's not any scarring associated with this. It typically resolves after treatment. And so one pearl for psoriasis, especially in darker skin types, is that you might not see the redness or erythema. It's often less visible, especially in cases of treated psoriasis. In this case, this patient had a pretty acute case of alopecia, so you could appreciate that redness, but that's not always going to be the case. And then this is this always makes me smile when I look at this photo. This patient was treated with a biologic, and this was about 6 months after treatment. And so you can see he has all his hair back, and then his lower leg, you can see that this is now a patch. So it went from a plaque, which is raised, to a patch, and he just has this residual post-inflammatory change. But all that scaliness, that micaceous scale, is now resolved. So for psoriasis, again, when we're trying to make this diagnosis, we're looking for sharply demarcated erythematous plaques. The scale is silvery white or micaceous. You can see an auspit sign if you gently scrape the scale, which most of us really don't do. But if you do that, or a patient were to try to remove the scale, you can see pinpoint bleeding due to all those dilated capillaries. Common sites for psoriasis typically involve sites of trauma, so think about elbows and knees, but it can also involve the scalp, also the nails, hands and feet, and intertriginous areas. You can have psoriatic arthritis as well. We see that fairly commonly, especially if these patients have nail involvement. It's often an asymmetric oligoarthritis, so an arthritis that affects the small joints, typically of the hands. Psoriasis can itch. It's not nearly as itchy as eczema, but again, it rarely is infected. So you don't see you don't see yellow crust or edema or weeping. Common triggers include trauma, medications. Some notable ones would be non-steroidal anti-inflammatories as well as beta blockers, stress, and then infection. So particularly for outbreaks of guttate psoriasis, you always want to screen your patient for a streptococcal pharyngitis. This is an example of a patient I saw recently. So this is psoriasis. This is a great board style photo because you can see that distal onycholysis. You see that end of the nail has lifted up. And so that's a very characteristic feature of psoriasis. You can also see pitting of the nails, salmon patches, oil drop spots. There's a lot of nail changes. And if you ever see a patient with psoriasis who has nail changes, you definitely want to ask them about any joint pain or joint symptoms. And then this is a dermoscopy photo where you can really see those dilated capillaries as well. And then the onycholysis here. And then this is a dermoscopy photo of a classic plaque of psoriasis, where if we zoom in, you can really see that nice scale with vessels as dots, which is a common feature of psoriasis. All right, case 3. This one's a little bit more challenging. What did we think about this case?
For this, we have dermatitis, pityriasis, and psoriasis.
So this one is actually tinea, or the so-called ringworm. And this one's hard. So if you guys didn't have a KOH readily available, but let's look at the features. So the clues here are you see these annular scaly patches, and annular implies central clearing. And so if you look in the center, you have this cleared area. And then typically you will see these inflamed, often palpable borders, which you see here and on the medial aspect. And so the pearl for tinea is if it's a non-classic case, if it's not psoriasis, it's not classic eczema, and you see scaliness and redness and those inflamed borders, it's always a good idea to scrape it. And in this case, you would see a positive KOH. These are just some more examples. So on the left, this is like the most classic presentation you could probably ever see. So inflamed border in that annular or central cleared area. On the upper right, this is actually a case where the tinea has involved the hair follicle. So in this case, you see more nodules also with the scale. So this type of condition is called Meioki's granuloma, and this patient needs to be treated with an oral antifungal because the topical treatments won't completely resolve this. And then Dr. Davis mentioned tinea incognito, this is a tinea infection where the patient has been treating this with a topical steroid. So this patient came to me a couple of weeks ago and said she had been using hydrocortisone for almost over 6 months. And I scraped it in clinic. This is a picture of that, the best one I could take, and it was KOH positive. So for tinea, especially tinea corporis, you want to think about those annular scaling patches that have inflamed borders. You can also have tinea pedis. It presents as erythema with scale, or you can typically see maceration between the toes, and it commonly affects the sides of the feet. As I mentioned, Meioki's granuloma, these are erythematous nodules, so this involves the hair follicle. And then tinea cruis, like Dr. Davis mentioned, this spares the scrotum compared to candidiasis, which typically involves the scrotum. So another tip about a tinea infection, you will need a systemic antifungal if the hair follicle is involved. So examples would be tinea capitis, Meioki's granuloma, tinea faciei, which is tinea of the face, and tinea barbae, which is tinea of the beard area. All right, case 4. What do we think about this?
For case 4, we have dermatitis and pityriasis.
Okay. So this is actually a case of lupus, particularly subacute cutaneous lupus. So let's look at this. So the main clue for this is that it's photodistributed. So you see this rash in sun-exposed areas. So in this patient, you see it on the V chest and then her extremities. And subacute cutaneous lupus is a form of lupus. And so this can present as red or scaly thin plaques and also annular plaques as well. So it can sometimes mimic other conditions like dermatitis, tinea, or psoriasis. But the main clue here, again, is that it's photodistributed. So it spares the areas covered by clothes. And you can see that with this orange arrow here. So for subacute cutaneous lupus, so again, this is a subset of lupus that presents as psoriasiform or annular plaques. Remember that you have to look in sun-exposed areas, so you really do need to examine the whole patient. Usually this does not scar compared to discoid lupus. You really only can see these post-inflammatory changes. It's more common in women and more common in whites. When we think about the classic lupus-associated rash, the malar rash, or the so-called butterfly rash, this rash typically spares the nasolabial folds. And when you see that, that's going to be more common to see with systemic lupus. In a lot of patients with subacute cutaneous lupus, less than 50% will have or go on to develop systemic lupus. So you would still screen these patients with an ANA, and particularly in SCLE, these patients will be anti-Ro or SSA positive. You can still have systemic findings, so a lot of these patients will have arthritis and arthralgias as well. And sometimes this can be triggered by medications. Some of the more notable ones would be hydrochlorothiazide and terbinafine. All right, in case 5.
For case 5, we have tinea.
Awesome. So this is actually pityriasis rosea. Let's talk about why. So the clues to diagnosis. Remember that herald patch. It's a pink enlarging plaque with scale. This is usually the initial rash that we see with pityriasis rosea. And then this will often have a trailing collarette. So the erythema, the redness, is in front of the scale. But the most helpful clue, in my opinion, is that the long axis of these ovals, so this axis, is oriented along Langer's lines or the skin folds. And I'll show you that in a minute. So this is an example from an orthopedic journal, but it really does a good idea showing you the lines of this skin folds in this axillary region. And so what you can see here by this teal line is that all these oval lesions, that long axis, is in the lines of the skin folds. And so like typically for a cutaneous surgery, we orient our scar in these skin fold lines. But whenever you see this in the context of something red and scaly, you really want to think about pityriasis rosea. So again, the initial onset, you can see that herald patch, which is that pink enlarging plaque. You don't always see it, but it's one of the more characteristic features. And then you'll see this diffuse eruption, which manifests as pink and scaling thin plaques, often with a trailing scale. It does tend to favor the trunk, and just remember that the long axis of those ovals is oriented along Langer's lines. Other clues, this is usually preceded by a viral illness. It tends to peak in the spring and fall, and it typically lasts a long time. So a lot of patients will complain that it doesn't seem to be going away, but just continue to provide reassurance and let them know that it can last 6 to 8 weeks. This can involve the intertriginous areas, which can be very uncomfortable, and this can also sometimes be caused by medications as well. All right, in case 6.
We have lupus.
Okay. So this is your classic atopic dermatitis patient, okay? So the clues here, there's several clues, but what I want you guys to look at first are what we call Denny-Morgan lines. So these are these creases here below the eyes as indicated by that teal arrow. We also have central facial pallor, which is evident with atopic dermatitis, lichenification, so you can see those increased skin markings where that orange arrow is. And then you can also see excoriations, which lets you know this patient is very itchy and that they've been scratching, and that's that white arrow. So compared to psoriasis, these patients have increased risk of secondary infections as well. So this just shows how eczema can become secondarily infected. So there's less of a defense mechanism against infections in these eczematous lesions. And so you will typically be able to recognize this. The patients might complain of pain, and then you will often see these sort of yellow serous crust. So that's why usually in the clinic, we'll tell patients that they could consider doing a bleach bath or using Hibiclens that can help decrease their risk of secondary infections. This in particular is a staph infection, but you can also see viral infections such as like eczema herpeticum as well. And then these are classic sites that you will typically see atopic dermatitis. And so this is like a subacute dermatitis or subacute spongiotic dermatitis. What you see here is that eczema typically likes the flexural areas. So This is in the antecubital fossa, and then you also see how in the skin folds here, this patient is very red, and this patient was extremely itchy. And then if this goes on long enough, so this is now what we call lichen simplex chronicus, and what this is a result of just chronic rubbing, because these areas are so itchy. So basically the body's forming like a callus, and then you can see how prominent these skin lines are. And then that also results in significant post-inflammatory change as well. So some people will call this alligator skin, but we refer to this as lichen simplex chronicus, which is essentially a chronic eczematous process. And you can see other features with atopic dermatitis. We went over the Denny Morgan folds. In darker skin types, you can have very notable periorbital darkening. And then you can see keratosis pilaris that presents as these follicular papules on the back of the arms. Also notable in darker skin types is follicular prominence. You can see this goosebump-like appearance, and you should always evaluate the patient's palms, because sometimes you can see what we call hyperlinear palms, which can be a sign that they have some underlying eczema. And so when we talk about dermatitis, I kind of lumped it all together because I feel like it's easier to understand, especially if you're not in the weeds of picking something out between allergic or chronic or acute. So when we think about acute dermatitis, this is going to manifest as erythema with edema. So there's going to be some swelling there. If that goes on long enough, you'll see some oozing as well as some vesicles. When dermatitis is subacute or chronic, that's when you start to see lichenification with increased skin markings, post-inflammatory change, excoriation, and nodules. And again, remember, common sites different from psoriasis, because this is going to more commonly involve the flexures, especially in adults, can also involve the face, neck, acrocytes, and eyelids. So if you're diagnosing someone with atopic dermatitis, it typically follows in the intrinsic eczema category. So these patients will often have allergies and asthma as well. The essential feature here is they're going to be very, very itchy. And then just remember that these patients have impaired barrier function, so their risk of cutaneous infections is increased. And then lastly, what do we think for this one?
We have dermatitis.
Yes, great. So this is like chronic dermatitis, very similar to the patient that I showed you before, but this is essentially gone on for a long time. And so the clues here, you can see this lichenification, so thickened or leathery skin, some post-inflammatory changes, and those increased skin markings. So when you talk specifically about hand dermatitis, this can be part of an intrinsic process like atopic dermatitis, or it could be extrinsic, so something that a patient is coming in contact with. These are some more examples of contact dermatitis. So on the left, this was an acute contact dermatitis from Lysol spray. And I want you guys to note the involvement of the creases, which is very common to see with an airborne contact dermatitis. You can see in the middle, we have a contact from neomycin that was applied to a wound. And the other photos show severe adhesive allergy. This can be acute, sometimes allergic, but often irritant. And so you can see here, this was redness from a bandage after surgical excision. And then you have severe allergy. I think this patient was using a bandage that also had Neosporin in it. And then you can sometimes see this like mild irritant dermatitis from just the adhesive on the bandages as well. But one important thing to point out is how linear these borders are, and that can sometimes be a clue to a contact dermatitis. So there's different forms. You can think about irritant. It's not immune mediated, so we're all sort of capable of getting an irritant contact dermatitis. We typically see that with new skin products, fragrances, repeated exposures. Can also be allergic. So this is your classic like poison ivy reaction. So it's delayed hypersensitivity. So you have to have an initial sensitization first. And then as I mentioned, If you see these sharp borders or lines, this is suggestive of a contact allergen. So you want to think like this has got to be something coming from the outside, okay? And then this is an example. I think I've showed you guys this before. This is a dermoscopy photo of an irritant contact dermatitis. Really what I'm showing here is instead of just diffuse vessels as dots, this is a typical patchy distribution of vessels as dots. And you can also see this sort of yellow, we call this the yellow clod sign, which is pretty consistent with an eczematous process. So great job. We differentiated between common red rashes and we recognized different presentations of dermatitis. So for the last minute or so, I'm just going to go through these cases and I just want you guys to kind of type in the chat and the same answer choices, okay? And we'll be quick because I know we're kind of short on time. All right, so question 1. Or actually, if anybody wants to speak up, that's fine too. All right. So the answer to this is,
Psoriasis?
oh, good guess. This is actually the classic malar rash of lupus. And the main clue here is that this rash spares the nasolabial folds. This is also a young female. I put in there about nothing on her hands because sometimes you can confuse this rash with the rash of dermatomyositis, which you would typically see Gottron's papules over the knuckles. But with dermatomyositis, this facial rash often involves the folds. So when you see a rash that spares those nasolabial folds, you want to think about specifically systemic lupus, because when you see this rash, there's a high chance that this patient has systemic lupus. All right, anybody want to try this one? All right, so remember what I said about the Langer's lines. So this is another example of pityriasis rosea. So you can see how the long axis of that oval is oriented within this patient's skin line. So a nice example of pityriasis rosea. All right. So I'll go ahead and talk through the rest of these because I want Kenji to have his time to shine. But this is an example of guttate psoriasis. And so this is an acute eruption that you can see these guttate or raindrop size plaques. And so this is characterized by those erythematous, well-demarcated borders. And this is typically symmetric. And then the other clue here is that often psoriasis, if it involves the feet, remember that trauma often triggers psoriasis. So here you can see that the psoriatic plaques spare the instep, which is, not something that is chronically touching the ground. So just a little clue there. Question 4. So this is an example of tinea. It has that classic inflamed palpable border with central clearing. And then remember I said this can involve the sides of the feet. So you see it here on the instep as compared to that previous example I showed you of psoriasis. And then this one is an example of a contact dermatitis. So this patient came to me, was very concerned, but he had recently been in the hospital and had EKG leads placed. So this is a contact dermatitis. And remember the clue here. You can see those very sharp borders, so you know that it's an outside job. And then this is an example. The main clue here is that you can see vesicles, right? This is very edematous, very acute. This patient had had an exposure at work. And so this is an acute dermatitis. And you can see that here with the edema and vesicles that have formed. And then last one, this is more of a subacute or chronic dermatitis. You really don't see a lot of scale here, but if you look here, you see that this patient's axillary vault is spared. that's a clue that this could be caused by an allergy to her clothing, perhaps a detergent that she was using. And you can actually see some of these increased skin markings. So she's had this for, a little while. So I think that's it. Awesome. Thank you for your attention. I'm really sorry the poll didn't work. I was kind of bummed to hear, but we will, those are my references. We will work on the poll because I do think it would be really fun and it'd be a great way to assess everyone's performance and just make sure that we're giving you guys the most out of these lectures. So I hope you enjoyed it and I hope it was useful, and just feel free to reach out if you have any questions.
Thanks, Dr. Buchanan. That was great. And it's certainly relevant to what people who are on the front lines of primary care see walking in their office every day. We do have a couple of questions, but I don't want to rob Kenji of 1 second of his time. So it's my pleasure to introduce Kenji Yoshida. He's listed as a third-year medical student. He's actually in what we refer to as the enrichment phase now. He's finished his clerkships and he's moving on into his areas of specialty. So Kenji, I'm just going to turn it over to you. Thank you.
Thank you. So my name's Kenji. I'm a third year / fourth year now. And this is a case that I've been working with Dr. Buchanan. So we have a 32-year-old Hispanic male who's had a itchy rash for 2 years, primarily on his face, neck, and arms. It's been progressing. He was born in the United States, but his parents were originally from Costa Rica. He's never had a biopsy, and he's not currently treating it with anything. So here's an image of this individual's neck, and here's a picture as well of the back of his neck and his arm. If you would like to put a differential in the chat, you're more than welcome to. This one's kind of a hard one, I will say. But this is the differential that we came up with. Sorry. We came up with erythema dyschromicum persistans, which is at the bottom in that image of a patient's axilla. Then we have lichen planus pigmentus, which is at the top. And then on the right there, we have pigmented contact dermatitis. We also have the differential of idiopathic eruptive macular pigmentation and multiple lesions of fixed drug eruption. We swiftly crossed out pigmented contact dermatitis through a history. He was not using anything that was coming into contact with the area that was diffuse as his, and it did not fit the differential. We also crossed out idiopathic eruptive macular pigmentation and fixed drug eruption. So on dermoscopy, he had this typical, like this bluish hue and erythematous margins, as you could see. It can also, from this area, was very easily confused with LPP versus EDP. However, there's this gray-blue small dots that you can see in the center of these lesions that will be a huge clue for later. And this is another photo of dermoscopy as well. It's interesting how there's these lines within the skin that are spared from this pigmentation that you can see. It's almost like this grayish brown pigmentation that's formed into dots and globules. So on pathology, we did get a biopsy of this patient, and it showed an interface dermatitis with post-inflammatory pigmentary alteration. And the pathologist read this as it could be more likely lichen planus pigmentus, or could be EDP as well, which is, again, erythema dyschromicum persistans. And this is what the histology slide itself showed. You note in this circle that there's this deep pigmentation in the dermal layer, which will be extremely important for treatment of this patient's condition. Some general demographics of this patient's condition. Again, ashidermatosis, or AD, is the same thing as erythema dyschromicum persistans. You can see that it's more common in females than males. It's more common in individuals with a mild to darker Fitzpatrick skin type, so they're more on the dark side with a 3, 4, or 5. Lichen planus pigmentus is more generally itchy compared to ashy dermatosis, as well as it has a few other co-contaminant infections such as lichen planopilaris and hepatitis B and C. So this is just histology or dermoscopy findings of patients with ashy dermatosis versus LPP. Those with ashy dermatosis more likely had this slate gray appearance that you could see on dermoscopy versus the brown gray, which was more common in LPP. There was more likely to be a diffuse hyperpigmentation pattern on dermoscopy for those with ashy dermatosis versus a reticular hyperpigmented pattern in those with LPP. Face and neck localization was roughly the same, but more hedged to LPP for that. It was more likely to be found on the back and abdomen by a large margin for those with ashy dermatosis, which is a little contrary to our patient. Flexor involvement was more likely to be seen in lichen planus pigmentus as well. So we ended up going with the diagnosis of erythema dyschromicum persistans, which is generally caused by drugs, contact allergies, infections, and chemicals. Some of the drugs that are associated with this were PPIs, chlorpromazine, amiodarone, thiazides, tetracyclines. Infections were usually viral, but also has been noted to be whipworm infections. And then some of the chemicals were ammonium nitrate of note. The treatment options for this condition, like I mentioned before, if you go back to this pigment that you see deep in the dermis, right? That means it's more going to be a harder treatment that you can't really treat topically. So for that, that's why we have treatments such as dapsone, griseofulvin, hydroxychloroquine, tacrolimus, and clofamazine. However, for appearance, you can use topical steroids, laser therapy, and chemical peels. But again, and with it being such a dermal process, that would take a long period of time of treatment before the patients are going to see satisfactory results. In summary, we had a 32-year-old Hispanic male, which fits the demographic, who had a itchy rash on his neck, forearms, and trunk for 2 years. And overall, dermoscopy is very useful in conditions like this for patients who have hyperpigmented disorders. Histopathology can be indeterminate. Like that pathologist said, it can be EDP versus LPP, and it's more likely to be related with clinical judgment to come up with a diagnosis. Also, as always, we all know, consider the patient's goal of treatment. If they're, extremely pruritic, but the appearance is not bothering them, then treat their symptoms rather than, just their appearance. But if they are bothered by their appearance, it just reinforced that it may take time to treat this condition. Any questions from anybody?
Thanks, Kenji. That was great. I did have a question. It seemed like the itching part may have been a key element of the patient's presenting complaint. Do the systemic drugs help with the itching, or do you wind up treating the itch with topicals? How's that work?
From what I found, the treatment options, some of them could help with the itching, but not all of them. So some people would prescribe both, say dapsone and a topical steroid, which would kind of knock out both at the same time. But again, this was a condition that, took quite a while for it to resolve, with it being a dermal process.
I have a quick question too. Oh, I'm sorry.
Kenji,
Go
can you
ahead.
stop sharing your
Sheldon?
screen?
Yes.
It's actually a two-part. Does the drug eruption coincide with the length of using the drug, or can erupt with a kind of a single or just minimal use? And then what do we think was the underlying cause of this person's condition?
So what I found was it can actually pop up as quickly as just a few uses of the drug, especially with those like tetracyclines. And I'm sorry, what was your other question?
What was the cause in this of the patient? What was the underlying cause, did we think?
That one I will turn over to Dr. Buchanan.
Yeah, I think the main teaching point here is that this is a rash that we can see in Hispanic patients, Latin America patients. And so it's just important to be able to recognize in this particular case, it wasn't caused by any particular drug or exposure. But I think that blue sort of grayish hue, as well as those patches were also oriented in the skin folds. And so it can just, this case was a very classic clinical presentation. And it's just important to recognize that. And in this patient, we actually didn't pursue any type of oral treatment. I gave him tacrolimus or Protopic for the itch, and he was completely fine with that. And then we always recommend sun protection because any amount of sun exposure can make these areas darker.
That's great. Thanks, Dr. Buchanan. While we've got you, on one of the questions that came in early on your case was from Michael Austin about the Harrell patch. Does the Harrell patch present differently in darker skinned individuals?
It's very similar. You still want to look for that sort of collarette of that trailing scale. And in darker skin types, it can be tricky. In some cases, I've seen it present as a little bit lighter than the patient's natural skin color. But then if it goes on long enough, you might see more of that post-inflammatory hyperpigmentation as well. But typically you will see that scale, which can be a good clue, as well as the orientation along those Langer's lines.
Looking to see if there's any other questions
Yeah,
from the group.
I was going to say that sometimes in darker skinned individuals, the scale is not quite so fine. It can be broader. It can actually be a little bit more inflammatory and a little bit more aggressive. And so sometimes we'll be more aggressive with our therapy, just knowing how darkly hyperpigmented the skin can be left afterwards.
Yeah, and that was one thing that I didn't mention is we typically don't treat pityriasis rosea, but particularly if it is in a very uncomfortable location like the intertriginous areas, or in cases that we are, potentially concerned about post-inflammatory changes. I've had to select patients over the years that we've treated with valcyclovir just to sort of speed up the resolution.
Yeah, I agree with that. I was going to say there's nothing worse than someone who's got a wedding in 2 weeks and then they get pityriasis rosea, and you're going to pull out all the stops for those patients.
Well, I was thinking about the poor guy who came in with itching. He wasn't worried so much about the hyperpigmentation, but the itching might have been keeping him awake at night. So that's a good point. I'm going to call on Dr. Rosenbaum. I saw that she mentioned in the chat she had some residents with her. We welcome you and your residents, and just checking to see if maybe from your room, if there's any comments or questions, Dr. Rosenbaum. Sorry for calling you out.
Right. Yeah, I don't think we have any questions. Any questions, guys? Okay. All right. Thank you.
They're all okay.
Thanks for
Thanks
being
a lot.
here.
Yeah, we appreciate everyone's attendance. And so with that, I just want to kind of wrap it up and say that for the end of the season, if you will, this is a great topic for us heading into the summertime when sun exposure can elicit some of the worst exacerbations of sort of the chronic subacute kinds of rashes that we talked about today. And so I'm grateful for this presentation from you, Dr. Buchanan, and also Kenji did a great job, and we appreciate you, and you're welcome back on the Southwest campus any single day. So with that, I'm going to turn it back over to you, Dr. Markowitz.
Okay. Wow, what a session. Those were some really great cases. I know my father for many, many years had psoriasis, and I'm, quite familiar with his very scaly, arms and chest. And back then, I think the treatment was just topical, and I think he would sit under a UV lamp or something. But obviously there's a lot more available these days for it. Anyway, so yes, we're going on a 2-month break. And during this period of time, we'll be deciding on what presentations we'll be doing during the next academic year. So any of you, if you have particular subjects or areas that you would like us to talk about, please send an email to teledermatology@augusta.edu. We really would love to have your suggestions. This year we spent a lot of time on more general dermatology issues and cases. Last year we did a lot of dermoscopy and training and so forth. So let us know. We have a lot of new people that have certainly that are here. A lot of different people who are here today than were here a year or a year and a half ago. And so we're happy to repeat topics or expand more. So please let us know. Again, although we're taking a break with the TeleECHO sessions, we still are continuing with the clinical consults. So feel free to send in your consults to Dr. Buchanan. And let's see, the CME code is on this slide here, and it's somewhere in the chat, and you'll get an email. And I think, again, thanks to the presenters for great presentations. And I think we can end it now. Reminder to the TeleDerm team members, hub members, to stay on for a few extra minutes, and all the clinical PCPs and other guests are free to sign off now. So have a good couple months of summer, and we'll see you back in August.
Thanks, everyone.